Hi, my name is Dr. Frederick Meyer, and I'm going to spend a few minutes providing some information and thoughts about ischemic neuronal injury. I'm going to particularly try to focus on what we can do as neurosurgeons to try to ameliorate ischemic injury if it occurs during surgery. Before we start thinking about the pathophysiology of ischemic injury, we need to appreciate a few basic facts. The brain is an amazing organ. For example, even though it only represents 2% of body weight, because of its need for a near continuous delivery of oxygen and glucose to sustain oxidative metabolism, it has high metabolic demands. It consumes 15% of our resting cardiac output. It utilizes 20% of our inspired oxygen at rest, and as you can see here, it essentially consumes the liver's entire production of glucose in the resting state. Much of this, of course, is to support metabolic membrane function. The continuous depolarization of neurons require preservation of ionic channels and ionic gradients across the membrane for depolarization. All that is ATP dependent, and hence the need for a high delivery of oxygen and glucose. But we'll get into that in a moment. I've listed here some basic physiological facts. Cerebral blood flow is approximately 50 mLs per 100 grams per brain tissue per minute. That's in the awake individual. Of course, under surgery, under anesthetics, cerebral blood flow will decrease most of the time because of suppression of cerebral metabolic rates. You can see here I've listed the metabolic rates for oxygen consumption, glucose, and lactate, just for your reference. In the future part of this talk, we're going to go into changes in blood flow and thresholds of ischemia, but we're going to reference this 50 mLs as a baseline normal blood flow. From a clinical perspective, there are two types of brain ischemia. The first is global or complete cerebral ischemia, and the second is focal or incomplete cerebral ischemia. So as illustrated here, global ischemia is the type of ischemia where for a period of time there's no perfusion to the brain, like a cardiac arrest. Focal cerebral ischemia is the type of ischemia that as neurosurgeons we're going to experience, for example, in surgery and other clinical settings. If you perform carotid endarterectomies, for a period of time the carotid is occluded and there's a potential for focal cerebral ischemia beyond the carotid artery, depending on collateral blood flow. An embolic stroke to the middle cerebral artery is focal cerebral ischemia. Temporary occlusion of a parent blood vessel while dissecting out an aneurysm is another type of focal cerebral ischemia. The concept of focal cerebral ischemia is there's a core region of brain that may have profound blood flow reductions, but then is surrounded by a peripheral area of brain that may have partial perfusion due to leptomeningeal collateral, suggesting that there may be reversibility. We're going to approach that concept using the term ischemic penumbra, but it all depends on the concept of focal cerebral ischemia. Now, focal cerebral ischemia may actually be metabolically more complex. Consider, for example, a state where you have some perfusion and hypoxia, but with continued glucose production and supply, which can increase the production of lactic acidosis, for example. I have borrowed this drawing from Dr. Lindsay Simon and his colleague Dr. Astrup, who some decades ago first described the concept of an ischemic penumbra. As illustrated here, a core region of dense ischemia, early infarction, surrounded by a region of moderate ischemia, moderate hypoperfusion with potential delayed infarction or reversibility, the penumbra. From my perspective, I'm going to divide it into what we will call a geographic ischemic penumbra and then a functional ischemic penumbra. So the geographic ischemic penumbra is illustrated here. This would be, for example, a middle cerebral artery embolic event, a core region of dense ischemia depending on the lodging and location of that embolus, but with perhaps potential perfusion from leptomeningeal collaterals from the anterior cerebral and posterior cerebral arteries, providing some peripheral perfusion and potential attenuation or delay in infarction. In the original description of ischemic penumbra, this is the drawings or concepts that were proposed. This is the second type of use of the term ischemic penumbra, and I'm labeling it as functional. So the last slide was geographic. This is functional. Now, as we discussed earlier, normal blood flow is approximately 50 mLs per 100 grams of brain tissue per minute. As it turns out, if you reduce cerebral blood flow to approximately 18 mLs per 100 grams per tissue per minute, one can see attenuation in electrical function as evidenced by changes in an EEG or an SSEP, a threshold of electrical failure, so to speak. If cerebral blood flow further declines to approximately 8 to 10 mLs per minute, one can reach a second threshold of what is termed metabolic or ionic failure. At that low level, one starts to see significant fluxes in cations inside and outside the cell, indicative of membrane failure, pump failure due to a depletion in ATP. Between the threshold of electrical failure and metabolic failure, you have a small zone of blood flow reductions in which there may be loss of function, that electrical failure, but enough preservation of metabolism to support membrane function. So a reduction in blood flow between the threshold of electrical failure and threshold of metabolic failure. I would suggest to you that this could be the physiological explanation for a TIA. A patient with a TIA comes and presents with a loss of neurological function, meaning their blood flow is below that threshold of electrical failure. But they recover, which would suggest that there's enough residual blood flow to prevent metabolic failure. Historically, a lot of the fundamental work on cerebral ischemia was done by neurosurgeons, and therefore I'd like to emphasize some of their seminal research with some of their original slides. So this is a depiction of the threshold of electrical failure. This is a collection of EEG tracings obtained by Dr. Sunt during carotid endarterectomies. And during that time, not only was cortical EEG done, but also blood flows were measured. So if we take the first patient, for example, you can see there's a normal fast EEG activity. And note that baseline cerebral blood flow is 72. So you might ask, wait a second, I just said normal blood flow is 50. Why is this 72? Well, this patient was under halothane anesthesia, and halothane is a vasodilator. Note that after clamping of the carotid artery, there's a slowing or attenuation in the EEG. You can see the slowing as evidenced by a delta rhythm, and blood flow drops to 17. And the right there, the shunt has been placed, blood flow through the shunt is 50, and there's return of fast activity. The second line of tracing, same phenomenon, baseline blood flow is 48. Upon cross-clamping, blood flow drops to 15. You see significant slowing or attenuation with a broader delta. On the right, a shunt is placed. Blood flow through the shunt is 57 with return of fast activity. And the last one is most impressive. In that 77-year-old patient, the artery's baseline is 35. The artery's occluded. Blood flow drops to 5, and that's below that threshold of membrane failure. And you can see a profound attenuation and slowing in the EEG. A shunt is quickly placed, and blood flow returns to 56. So by collecting a large series of EEGs in this way, Dr. Sunt and Dr. Charbrough and their colleagues first described the threshold of electrical failure based on scalp EEG recordings during carotid endarterectomy. This is a slide from Dr. Simon, Astrup, and Branson in their classic studies on focal cerebral ischemia, which actually demonstrates both the threshold of electrical failure and the lower threshold of metabolic failure together. So if you turn your attention to the top, EP is electrical potential. That's threshold of electrical failure being illustrated, as you'll note that the clip is at 0 when about 1 minute out there, 1 hour out. There's a significant attenuation in evoked potentials. The threshold of electrical failure has been reached. You can see in the middle graph the declines in blood flow. As the clip stays on and blood flow continues to decline, in their extracellular potassium recordings, you can see about 2.5 hours out, there's a sudden increase in extracellular potassium, membrane failure. So again, you see in the top electrical failure and in the lower ionic failure. This slide and the next slide happen to be from my laboratory. This slide measures several different things. It measures extracellular potassium and calcium, chloride, sodium. We measured extracellular pH and electrical potential. And so this is really starting to look at the threshold of ionic or membrane failure. So for example, you can see in the lower x-axis, you can see ischemia and recirculation are depicted there. And so during ischemia, we can see that in this experiment, there's rise in extracellular potassium, a significant decline in extracellular calcium, a significant decline in extracellular sodium, a significant acidosis, extracellular acidosis from 7.4 to 6.6 within 10 minutes of ischemia due to the lack of oxidative phosphorylation. And ECS is electrical potential. So this slide again illustrates the thresholds of electrical failure and metabolic failure all in one, but it highlights some of the cation changes which we see in an extracellular environment, as well as the significant extracellular acidosis. This is an experiment in my laboratory. This is focal ischemia in an animal model where the middle cerebral artery is being occluded through a craniotomy. So in this experiment, we're measuring cortical blood flow using fluorescence, ATP, and lactic acid, as well as EEG. And so before occlusion, you can see there's normal fast activity on the EEG, and we have our baseline blood flow and ATP, and of course lactic acid is quite low. At time 0, the artery has been occluded. You can see shortly thereafter there's a rise in lactic acidosis, a decline in ATP, both of which correlate to the significant reduction in cortical blood flow. Note that the EEG demonstrates a significant slowing or attenuation, and so here again you're seeing both the threshold of electrical failure and the threshold of metabolic failure. At 2 hours, the clip is removed. We see slow resolution in lactic acid, slow improvement in ATP production. But I think the most dramatic finding in this particular experiment is the dramatic hyperemia that occurs after occlusion. Look at the top there and the significant doubling of cortical blood flow. The hyperperfusion that used to be seen in blood flow measurements in focal ischemia such as this raised the concept of free radical formation. In other words, with excessive oxygenation in areas of ischemia, the concern was this would produce free radical evolution, leading to reperfusion, injury, and damage. On a clinical perspective, of course, when you have hyperperfusion at that level, after vascular surgical cases, you worry about hyperemic hemorrhages. This is a lovely focal ischemia experiment, and you can see there that beyond measurement of lactic acid, we've measured several other things. Phosphocreatine, we've calculated out a energy charge, ATP, ADP, AMP ratios, intracellular pH using fluorescence, and free fatty acid formation. So this one experiment gives us quite a bit of information. During ischemia, we can see that there's a significant drop in a cell's energy charge. Not surprisingly, a significant drop in phosphocreatine. Predictably, there's a significant rise in extracellular lactic acidosis, but in this particular experiment, a dramatic drop in intracellular pH from about 7.0 to 6.5 shortly within 10 minutes of focal ischemia. This is in a core region of ischemia. And note also, and we'll get to this in a moment, the significant rise in free fatty acids. So this is a profound reduction in blood flow below that threshold of electrical failure, a serious loss in energy charge, and obviously the evolution or production of intracellular and extracellular acidosis, and the surprising finding of free fatty acid formation. So the obvious question, which has a straightforward answer, is why with severe blood flow reductions do we see significant changes in extracellular cations? Why do we see a significant drop in extracellular sodium and extracellular calcium? Why do we see a significant rise in extracellular potassium, for example? Why do we see a significant acidosis? Well, the explanation is straightforward and is of no surprise to any of us who took basic biology in college, and now I suppose same biology is taught in high school. But with that being said, we know that the membrane pumps, for example, the sodium-potassium pump, the sodium-calcium ATPase, are all ATP dependent. We know that energy is required to maintain the ionic concentration differences between the extracellular, intracellular space and neurons. I mean, this is the basic physiology for an action potential. With depolarization, sodium rushes into the cell, depolarizes the membrane, potassium goes out of the cell, and the action potential propagates down the neuron to the synaptic cleft, leading to neurotransmitter release. But that entire process requires ATP or energy. We already know that the brain is dependent on oxidative metabolism for ATP production. So it's of no surprise that when you have significant blood flow reductions, there's failure of oxidative metabolism, there's rapid depletion of ATP, there's rapid production of acidosis, and membranes depolarize. This nice artist rendition summarizes exactly what I just said. The need for ATP to drive and sustain the sodium-potassium pump, and the natural leakage of sodium and potassium inside and outside the cell due to concentration gradients. The regulation of intracellular calcium is complex. It's important to remember that under normal conditions, the concentration of extracellular calcium is 10,000-fold higher than intracellular concentrations, since there's a natural gradient forcing calcium to enter the cell. The maintenance of this concentration differential is multifactorial. So calcium can enter, as listed there, several different channels. There's the voltage sensitive channel, the NMDA channel, and an AMPA channel. The voltage sensitive channel, by the way, was thought to be a potential mechanism by which dihydropyridines such as nimodipine or nicardipine might be helpful in attenuating ischemic injury by limiting calcium entry through voltage sensitive channels. But the fact of the matter is they were not effective, and calcium can enter so many different ways that blocking one channel was just ineffective. It's important to recall that at the plasma membrane level, the extrusion of calcium out of the cell is an ATP ACE-driven export, a coupling between the sodium-calcium exchanger. It's 3 sodium for every calcium. It's important to remember that the regulation of intracellular calcium is quite complex. The extracellular concentration of calcium compared to intracellular is 10,000-fold difference. So to maintain that ionic differential between extracellular and intracellular calcium concentrations requires energy, or ATP. As you can see here, I've listed on the lower part of this pictorial the calcium ATPase is one mechanism, and the calcium sodium exchanger, which is also ATP dependent, exchanging 3 sodium to 1 calcium. These all require energy. Intracellularly, the endoplasmic reticulum is critical in maintaining concentrations of calcium within the cell, and that's ATP dependent. I'd also point out that the mitochondria also has function in that regard, again, ATP dependent. So I've listed a variety of mechanisms to preserve intracellular concentrations that are all ATP dependent. On the left-hand side of that pictorial, I've sketched out 3 different channels: a voltage-sensitive channel, an AMPA channel, and an NMDA channel that is glutamate sensitive. Historically, some years ago, there was interest in the dihydropyridine calcium antagonists because they were primarily antagonists to the voltage-sensitive channels, and it was thought that agents like nimodipine or nicardipine might have a primary ischemic neuronal protective benefit. As it turns out, they did not. But the explanation for that is obvious because look here, all the different ways in which calcium can enter the cell. It's pretty evident that if you're going to try to attenuate or block calcium increases intracellularly to pathological levels, you're going to need a cocktail approach. Why am I emphasizing calcium? Because the next few slides are going to demonstrate that calcium seems to be a key mediator or facilitator of ischemic injury through multiple different pathways. One primary mechanism of calcium-mediated neuronal death is illustrated here. This places primary importance on glutamate, an excitatory toxic neurotransmitter. So the concept here is that with ATP depletion and membrane depolarization because of failure to maintain sodium-potassium gradients, there's propagation of action potential down the neuronal membrane with excessive release of glutamate and aspartame in the synaptic cleft. This rise in these excitatory neurotransmitters has long been thought to cause opening of one of those calcium channels, specifically the NMDA channel, leading to an influx of calcium into the cell. It's long been thought that calcium influx into the cell at excessive levels turns on nitric oxide synthase, which subsequently leads to excessive production of nitric oxide, as illustrated here. As we appreciate, nitric oxide at a normal state is important for vasal regulation of focal cerebral blood flow, but at toxic levels or high levels can be injurious as a free radical. This slide tries to organize the central role of glutamate and calcium in ischemic neuronal injury, both on the apoptosis side and the necrosis side. Now, of course, this slide oversimplifies things, but it highlights some of the key concepts. So, starting off with massive membrane depolarization, we have release of glutamate into the synaptic cleft. Again, why is there massive synaptic depolarization? Because we have failure of ATP, again due to the lack of oxygen glucose delivery. We have failure of key neuronal membrane pumps, like the sodium-potassium pump is a starter, which leads to membrane depolarization. We also know that key pumps that help control intracellular calcium fail, again due to lack of ATP, like the calcium exchanger or the sodium-calcium exchange. We also know that key pumps along the endoplasmic reticulum, which again are ATP dependent, fail, all contributing to a rise in intracellular calcium. Now, as illustrated here, there's two basic concepts. On the left-hand side, the concept, as I tried to illustrate on the prior slide, a rise in intracellular calcium leads to the production of reactive oxygen species, leads to mitochondrial calcium overload because the mitochondria are trying to sequester calcium. That, in fact, leads to disruption of any residual oxidative phosphorylation within the mitochondria. You can see there leading to an increase in cytochrome C, an increase in caspase 3, leading to DNA degradation and apoptosis. On the right-hand side of the slide, try to indicate that the rise in intracellular calcium leads to activation of lipases and proteases, which start to degrade the cellular membrane. The cellular membrane becomes leaky, leads to lipid pair oxidation, protein oxidation, which again leads to free radical formation, but primarily here, membrane damage, leaking of cells, influx of sodium and chloride and water sequentially with cell swelling and necrosis. This slide nicely summarizes in a different way what we've been discussing in the prior two slides. It places, again, a central emphasis on intracellular calcium rises as a central mediator of ischemic injury, either apoptosis and or necrosis, and both. So you can see here, it's tried to summarize intracellular calcium leads to activation of capains, phospholipase A2, lipases, endonucleases, nitric oxide synthase, free radicals, of course, and disruption of mitochondrial function, specifically oxidative phosphorylation. The result of that is a sequence of things: mitochondrial damage, cell membrane disruption, production of free radicals, breakdown of the cytostructure, and DNA fragmentation. So moving forward, one could say, well, if you want to create some neuroprotective agent for ischemia, it needs to block entry of calcium into the cell. But as we saw, there's multiple pathways in which calcium can enter the cell during ischemia. So therefore, any pharmaceutical type agent or approach is going to have to be a cocktail approach to be effective. Beyond the calcium-mediated mechanisms, there are other pathways that compound ischemic injury. One, for example, is activation of inflammation. There's a number of pro-inflammatory genes which contribute to this effect, such as tumor necrosis factor, interleukin-1 beta, and transcription factors for hypoxia-inducible factor 1, nuclear factor, and interferon factor. These lead to superoxide radical formation and calcium influx into the zone of ischemia. There's a primary leukocyte-mediated event that contributes to this. Inflammation has many potential deleterious effects in the ischemic brain, as we would speculate. The accumulation of neutrophils, platelets, and blood vessels can be so intense that any residual blood flow from capillaries gets plugged just physically by the collection of these downstream products that inhibit microvascular perfusion. Many of these things can lead to breakdown of the blood-brain barrier, which leads to more rapid influx of inflammatory agents into the zone of core ischemia. It goes without saying that when you break down the blood-brain barrier, beyond the transmigration of leukocytes, there's extravascular accumulation of albumin and other osmotic compounds, which again lead to continued extracellular edema. Beyond other things, they lead to the risk of hemorrhagic conversion of a stroke. All this also promotes continued formation of free radical formation. I borrowed this slide from Dr. Ma. It's published in the British Medical Bulletin in 2005. I like it because it also demonstrates yet another potential pathway that compounds ischemic injury, specifically the release of catecholamines. And as they've tried to illustrate here, catecholamines in themselves can lead to deleterious effects, increasing neuronal demand at a time when there's a decrease in oxygen and glucose supply, potentially leading to vasoconstriction, which could compromise any residual collateral blood flow, potentially facilitating free radical formation and enhancing excitotoxicity. This slide I've copied from Dr. Dixon and Dr. Stockwell and their team that first described yet another mechanism of ischemic injury, which they coined the term ferroptosis. The concept here is that ferroptosis is an iron-mediated pathway for reactive oxygen species production. The morphological features of ferroptosis are slightly different than true apoptosis. Specifically, the cell membrane is intact, doesn't have ruptures or blebs. The nucleus is normal size, meaning there's a lack of chromatin condensation, but there's shrinking of the mitochondrial membrane, and that's a little different than the typical imaging of apoptosis. It's probable that ferroptosis is more relevant when you have intracranial hemorrhage, but I'll remind you that even in ischemic stroke, a certain percentage converts to an hemorrhagic infarction, and therefore ferroptosis may be relevant in that particular scenario. This stain of cortex subjected to ischemia demonstrates classic changes of apoptosis. You have shrinkage of neurons, you have clumping of chromatin, and condensation or collapse of the nucleus. This is distinct from necrosis, which tends to demonstrate cellular swelling and edema, increases in extracellular space. Recall that apoptosis, among other things, is related to caspases, calpains, primary injury to DNA, whereas necrosis is related to many extracellular factors, lactic acidosis, inflammation, complete disruption of the cell membrane with massive influx of water, sodium chloride, etc. In this electron microscopy image, on the left you can see necrosis, so we're seeing cellular edema, vacuolization within the cell. On the right we're seeing apoptosis, nuclear clumping, condensation of the nucleus. With that brief background about mechanisms of ischemic injury, I would like to move to how can we make this clinically relevant to neurosurgeons, neurologists, and neuroscientists. How can we somehow ameliorate or attenuate ischemic injury, whether it's planned, like temporary occlusion of a blood vessel during surgery, to spontaneous, such as a dissection or embolic stroke. So with that as a framework, This is a slide again from Dr. Simon from years ago. It's trying to put together, in my mind, the concept of infarction, necrosis. Remember, at the time when this was created, the concepts of apoptosis were not recognized. It places this concept of histology with blood flow. It emphasizes the concept of threshold of electrical failure or functional impairment, as was described here, versus membrane failure. Those are the cation changes we see, and the small zone of penumbra or viable tissue. So we're going to focus on that. Again, to remind ourselves of the concept of geographic ischemic penumbra, what I coin geographic, we have a zone of dense ischemia, evolving infarction, unless you immediately restore blood flow. It's probably going to lead to irreversible injury, surrounded by a penumbra region, a moderate ischemic region that is salvageable. Of course, whether a core is truly dense ischemia, irreversible injury, or not depends on collateral blood flow, right? So after middle cerebral artery occlusion, let's say with an embolic event, one might think that there's going to be an irreversible zone of injury, but in fact, I think clinically we found that patients can recover dramatically and remarkably for extended periods of time. And therefore, I think the concept of dense core ischemia is evolving and changing, and that the brain has better than anticipated tolerance of reductions in blood flow. This is an experiment that we performed. This is focal ischemia in an animal model of middle cerebral artery occlusion. On the left, you can see TTX staining of this animal, and you'll note that the white highlights an area of infarction or no perfusion in the distribution of the middle cerebral artery. The right side of the slide is using fluorescence, and using fluorescence, we're looking at intracellular pH of the cortical mantle. We're looking at NADH fluorescence, which is really assessment of mitochondrial function. And we're also measuring cerebral blood flow. And the point that I'm going to try to emphasize here, that the penumbra's physiological or metabolic state fluctuates over time, which I think emphasizes concepts of reversibility. So if you look at the very top line, 90 minutes, you can see there on the right side of each little panel, there's a core region of dense blood flow reductions, dense ischemia, dense severe intracellular acidosis, and I will assure you that that's evolves to an infarction. But surrounding that dark, dense zone is a bluish zone. That is the ischemic penumbra. And within the ischemic penumbra, you can see there's little islands of darker blue, which represents more significant acidosis within the zone of ischemic penumbra, but not really following, quite frankly, a vascular distribution. So first, this is, pictorial documentation of ischemic penumbra, right? But it also demonstrates that there's significant fluctuation over time within the ischemic penumbra. You can see there's some correlation between the severity and declines and fluctuations in blood flow and the severity of acidosis within the ischemic penumbra. So again, what this emphasizes to us is the variability of the ischemic penumbra and the fact that it is potentially salvageable. If you can institute changes immediately or as soon as possible, the best change, of course, is reestablishing blood flow. This is returning to a slide which I showed you previously, which is depicting what I'm terming functional ischemic penumbra. So breaking the penumbra into blood flow zones of reduction. Recall that normal blood flow is about 50 mLs per 100 grams of brain tissue per minute. The first threshold of functional or electrical failure is at approximately 18 mLs. A more severe drop in blood flow to about 8 to 10 is the metabolic failure threshold, or ionic failure, or membrane failure, however you want to term it. And therefore, between those two thresholds, we have this zone that I'm going to describe as the ischemic ischemic penumbra a small zone of blood flow reductions in which there's loss of function, but enough residual ATP production to preserve basic membrane function. I would suggest to you that the functional status of brain once a vessel is occluded is essentially summarized in the equation on the right. Whether brain has electrical failure of function, whether it has severe membrane failure, whether tissue dies, or whether it sits within that potentially reversible zone, is really summarized in the amount of residual collateral blood flow after vessel occlusion, the time of blood flow reduction, and how severely vulnerable is the tissue being subjected to ischemia. So we know, for example, that certain parts of the brain, certain cortical layers, the hippocampus, let's say the CA3 zone, have increased vulnerability to ischemia, probably related to the density of glutamate receptors. So this is not complicated. It makes sense. If you, for example, let's take a carotid endarterectomy. You occlude the carotid artery, and presumably there's some reduction in blood flow to the right brain or left brain, depending on which artery you're occluding, of course. You may detect that drop in blood flow based on EEG if you do intraoperative EEG or SCP measurements. So let's say, for example, you are doing the carotid surgery and there's a drop in EEG change, there's attenuation. The question is, how do you increase collateral blood flow? You could put a shunt in, of course. You could rapidly do the surgery, I suppose, to shorten the time of ischemia. Or what I found to be very effective is raising the mean arterial blood pressure. So before I cross-clamp the carotid artery, I'll increase the blood pressure to about 160, 170 systolic, if the heart's tolerable, if the heart can tolerate that increase in blood pressure, because that will enhance collateral blood flow. I found that if I use induced hypertension, which is what I'm describing, of course, my need for placing a shunt as guided by EEG in carotid surgeries dropped from about 1/3 to perhaps 5%, all by that simple manipulation. Well, that's pretty exciting. Let's say you are clipping an aneurysm, and you decide, for example, that you want to have proximal control with a temporary clip. Or let's say the aneurysm ruptures and you have the artery temporally occluded proximal to the aneurysm. Well, that area distal to that clip is being subjected to ischemia. If circumstances permit, if you intermittently release the clip so you can reperfuse the brain, that will attenuate the amount of ischemic injury and increase the time in which you can overall temporarily occlude the artery as you try to repair the aneurysm. It used to be thought that intermittent reperfusion in the setting of ischemia increased free radical formation, but that's really never been shown to be true. So the fact is, if I'm working on an aneurysm and I temporarily occlude a parent artery, within 5 minutes, 3 to 5 minutes, I try to at least reperfuse the brain for a minute or two, if I can, to prevent ischemic injury. If, let's say, you're dissecting out an aneurysm and it happens to rupture, you could, for example, you put a temporary clip on the proximal artery, and you could put a temporary clip on part of the aneurysm dome which had bled, right? And then take the proximal temporary clip off for brief periods of time to reperfuse, and then when the artery is occluded, redissect the neck and work back and forth until you finally secure the aneurysm. So that's how you increase, collateral blood flow. That's how you decrease the time of ischemia. What can you do to decrease tissue vulnerability to ischemia? Well, that's more complicated. There's an old literature of trying hypothermia. It's never really been proven to be efficacious, although it certainly is appealing in terms of decreasing cerebral metabolic rates. But the truth is that hypothermia or profound hypothermia probably is something of the past. I think most of the time now, anesthetics are the primary source of decreasing tissue vulnerability by decreasing metabolic rates and hence demand of oxygen glucose. So two that come to mind, of course, are propofol. It's short acting. Ketamine is another one. And thiopental. So if I know that I'm going to temporarily occlude an artery for surgery for, let's say, a ruptured aneurysm, I'll ask the anesthesiologist to use propofol. And if I'm really worried, I might ask them to infuse thiopental, 2 milligrams per kilogram. Thiopental is a little longer acting than propofol, but it certainly is effective. And there certainly are neurosurgery colleagues who have found ketamine to be very effective. Other ways to try to decrease tissue vulnerability is to make sure the patient's not significantly hyperthermic. That, again, is a playback to hypothermia. And to try to maintain normal glucose concentrations during ischemia. So that can be trickier than you think if the patient's on Decadron. But there's no doubt that hyperglycemia in the setting of ischemia leads to increase in lactic acidosis, which is harmful. So those are some ways currently that a neurosurgeon can help lessen the risk of permanent infarction when focal ischemia is occurring. Hopefully in the future, there'll be the development of more effective and direct pharmaceutical agents, primarily focused at glutamate, I would suggest, and also calcium entry into the cell. This is a beautiful example of some of the concepts we have discussed. So this patient presents with an acute embolic left middle cerebral artery event. You can see on image B, the arrow is pointing to thrombus in the left middle cerebral artery. Many years ago, we published a series of patients in which we would do an open surgical thrombectomy, meaning we would do a craniotomy, include the M1 and distal M1 segments, make a linear incision in the middle cerebral artery, extract the clot, and repair it with a 9 or 10 monofilament suture. That sounds more complicated than it actually was. And in fact, we found that about a third of patients made a great recovery from that surgical embolectomy. We also demonstrated that their recovery was completely dependent on the angiographic degree of collateral blood flow. Fairly predictable finding, I suppose. But we found that if there's good collateral blood flow from the anterior cerebral artery or posterior cerebral artery distribution to that middle cerebral artery area over leptomeningeal collaterals, then the time of ischemia was extended. No surprise. But nowadays, open surgical embolectomy is something of the past. It's an historical anecdote. And as we all know, acute stroke is being treated with catheter retrieval with remarkable results. And so this is an example of that. This patient has an embolus to the left middle cerebral artery. You can see there's on the image C, demonstrates a significant region of cerebral blood flow reduction in the distribution of the middle cerebral artery. You can see that in D. And then after clot retrieval, beautiful reestablishment of the middle cerebral artery, and the patient makes a great recovery and no stroke on MRI, and neurologically has done really quite well. Now, this, in my mind, demonstrates many, many things. The evolution of technology to the betterment of neurosurgery, obviously. It also demonstrates that it's hard to predict how someone's going to do. It really does depend, again, on blood flow reductions and collateral blood flow. So the time of permissible ischemia in this type of scenario has really been extended to the surprise of many, I think. So for older stroke researchers, the teaching was that if you had focal ischemia longer than 4 to 6 hours, all hope was lost. But modern day experiences in embolectomy have shown that that truism is no longer correct. That you cannot predict who exactly will suffer permanent injury. We do use MRI spectroscopy, looking for zones of severe ischemia. That may be helpful. I think introducing technologies to look at the degree of blood flow reduction, to quantitate it, to quantitate the residual metabolism of brain under risk will be important in trying to delineate who and who might not benefit from acute stroke intervention. This illustration nicely depicts the use of CT perfusion in acute stroke secondary to a carotid occlusion. It also demonstrates concepts of the ischemic penumbra. This was a middle-aged gentleman who presented with left-sided weakness, numbness, and neglect. In Figure A, you can see that a non-contrast head CT does not show evidence of a established infarction. On B, a CT of the head and neck demonstrates no contrast opacification of the right-sided cavernous sinus, suggesting a carotid occlusion. In Figure C, a CT perfusion demonstrates increased time to maximal contrast opacification in the majority of the right cerebral hemisphere, with reduced cerebral blood flow in two distinct areas, which are circled, concerning for establishing an infarct. In D, the infarct core was limited to two distinct frontal and parietal cortical areas, the magenta, while the penumbra included essentially the entire cortex of the right cerebral hemisphere is highlighted in green, yielding a mismatch between the penumbra and the infarction core of an MR ratio of 4.2. Figure E is the lateral angiogram, which demonstrates right ICA occlusion at the anterior genu of the internal carotid artery. F is thrombectomy and balloon angioplasty, demonstrating recanalization of the artery. Long term, this patient did really quite well neurologically. So in this one image, you can see a demonstration of acute imaging of vascular blood flow using CT perfusion, identification of an ischemic penumbra, and salvaging of the hemisphere by acute stroke intervention. Well, I hope that this brief presentation was some educational value and interest. I think there's a lot of observations, like technology is evolving. It's remarkable what has happened in the last few years in terms of the treatment of patients suffering from acute stroke. I think it's important to emphasize that much of the work I tried to describe was done by neurosurgical laboratories, which makes me proud as a neurosurgeon and translational scientist. I appreciate all of you joining me, and thank you.